In Lesson 2, we continue our physical examination of the patient, beginning with auscultation. Since this is our bread and butter, we won't delve further. However, a brief mention of the current use of electronic stethoscopes should be mentioned. Electronic stethoscopes allow the therapist to listen from a distance and may be increasingly used in telemedicine. This slide reviews the basic breath sounds, and special attention should be given to whether the sounds are continuous or discontinuous, with wheezing being a continuous adventitious breath sound with a constant pitch and varying duration, and crackles a discontinuous breath sound like brief bursts of popping bubbles. They are more commonly heard during inspiration and result from the sudden opening of closed airways. This slide illustrates the lung fields to be auscultated anteriorly and posteriorly and should be done in a systematic fashion from side to side for comparison. Some of the common errors to auscultation are noted here and the correct technique described, with the overall recommendation to eliminate as much surrounding noise as possible. Guidelines for interpreting breath sounds and their common causes are seen in this table, with decreased breath sounds suggesting hyperinflation from COPD or atelectasis, pneumothorax or pleural effusion, absent breath sounds from the above-mentioned plus obesity, bronchial breath sounds from consolidation, crackles due to secretions, wheezing from diffuse airway obstruction or bronchospasm and corresponding results of voice sounds, rubs, both pleural and pericardial, suggest inflammation. This slide further illustrates adventitious lung sounds and possible causes. Now we turn our attention to auscultation of the heart. Normal heart sounds are represented by S1, the lub, and represents closure of the atrioventricular valves, and S2, the dub, representing closure of the semilunar valves. Any other sounds are considered abnormal, with S3, which may be immediately heard after S2, a key sign of heart failure in older adults, but is considered normal in children, and S4, which may be heard just before S1 and is associated with atrial contraction and is commonly heard in patients with hypertensive cardiac disease, CAD, or pulmonary disease. Other abnormal sounds are murmurs, which are classified according to their timing, quality, intensity, pitch, location, and radiation, and are due to one of the three reasons. 1. High blood flow rates through normal or abnormal valves. 2. Forward blood flow through a stenotic or malformed valve or by flow into a dilated vessel or chamber. And 3. Regurgitation through a valve. Pericardial friction rubs are heard over the third or fourth intercostal space and sound creaky, with each beat or two like two pieces of leather rubbing together. The areas to auscultate are the aortic area, which is right second intercostal space just lateral to the sternum, the pulmonary area at the left second intercostal space above the sternum, the tricuspid area located at the inferior left sternal margin, and the mitral area at the fifth intercostal space. Palpation should also be considered as it evaluates the mediastinum for tracheal shift and the activity of the chest wall and diaphragm and circulatory status. Tactile fremitus assesses the lung fields for presence of secretions or consolidation, increased tactile fremitus, or increased aeration or fluid as seen in pleural effusion, COPD, or asthma, decreased tactile fremitus. Evaluation of circulation includes taking notes of hair loss, muscle atrophy, dry skin or ulcerations or gangrene. Doppler velocimetry may be used to identify patients with asymptomatic arterial disease or those with severely obliterated pulses. Percussion may be done to determine lung areas of increased density representing consolidation, which sounds dull to percussion, or tympanic sounds on percussion representing hyperinflation. Lastly, the physical exam should evaluate the patient's activity level in response to activity. Evaluations are made while the patient is resting, sitting, standing, performing an ADL, activity of daily living, and ambulation. Heart rate and rhythm, oxygen saturation, blood pressure, symptoms, heart and lung sounds before and after are evaluated during these activities. This evaluation should occur when the patient is considered stable after an acute event, but may even be performed when a patient is on a ventilator. Blood pressure is a critical factor to evaluate as it's a general indicator of heart pumping and is affected by both cardiac output and peripheral vascular resistance. Pulse oximetry is also indicated, but heart rate should be additionally palpated as low perfusion states may provide unreliable heart rates and oxygen saturation. These results should be recorded for each activity. The National Heart, Lung, and Blood Institute, NHLBI, sets the criteria for normal blood pressure defined as less than 120/80, prehypertensive systolic between 120 and 139, and diastolic between 80 and 89. Stage 1 hypertension, systolic between 140 and 150, and diastolic between 90 and 99. And stage 2 hypertension, greater than 159 systolic and greater than 99 diastolic. Recommendations for treatment include lifestyle modification for prehypertension, additional treatments of diuretics, ACE inhibitors, beta blockers, or calcium channel blockers for stage 1, and a 2-drug combination for stage 2. Normal responses to increased activity include a gradual rise in heart rate and a plateau in response to activity past the steady state, as seen in endurance activity, a gradual rise in systolic blood pressure and again a plateau once the patient reaches a steady state, a 10 plus or minus change in diastolic blood pressure with an increased activity or endurance activity, a gradual increase in respiratory rate and maintenance or increase in SpO2. Slide 68 summarizes the abnormal responses: a rapid increase of heart rate or a blended rate of rise and not on medications that affect heart rate in response to increased activity, or a progressively increasing heart rate or significant drop in heart rate in response to endurance activity, a regular heart rhythm that becomes irregular or more than 6 skips per minute or documented PVCs above resting amount for either increased activity or endurance activity, or systolic pressure rapidly rising or blunting and not on beta blockers or symptomatic responses. Diastolic pressure rising greater than 10 millimeters on either increased activity or endurance activity and decreased SpO2. Other symptoms that may be noted include angina, bronchospasm, esophageal spasm, shortness of breath, palpitations, dizziness, or fatigue. A thorough exam helps the RT develop a plan of care and an opportunity for reassessment at each intervention. This helps select the proper interventions and measures to evaluate progress or modify or redirect the plan. In future lessons, we will use this information to guide us when assessing patients in the acute care setting for rehab potential, in cardiac rehabilitation, pulmonary rehabilitation, or in pediatric interventions.